Great, thank you so much. We come from an institution where we do a lot of surgery for mesothelioma, so I can't tell you this is not against surgery at all. In fact, I'll talk a little bit about that at the end. But we're going to talk about the systemic therapy options and treatments and things that are new and coming forward now. So my disclosures, I have none. I'm looking for some if anybody's interested. So mesothelioma is historically thought of as a chemo-resistant disease. And this goes back to trials from the 80s and 90s, which really failed to show significant responses to systemic therapies. Median survival on most chemotherapy regimens back then was around 7 months. And just best supportive care alone was around 6 months. So really no real strong support for treatments in these patients. Single agent and combination therapies, things like cisplatin, doxorubicin, gemcitabine were used in patients, but there was no defined standard of care. And then came Pemetrexed. So this harkens back to 2003 with a Vogelzang seminal paper combining cisplatin as the control arm, and the experimental arm was cisplatin with Pemetrexed. This is the first study that showed a survival benefit to combination chemotherapy in mesothelioma. There was in the figure to the right, and it was patients who got supplemented with folic acid, which was found to be crucial to tolerance of this regimen. There was about a 3-month overall survival benefit, which was significant. And that became the standard of care. So cisplatin, Pemetrexed remains the gold standard for treatment of systemic therapy of mesothelioma. Carboplatin and Pemetrexed also effective, probably equally effective. There's been no randomized comparison, but in the expanded access programs and comparative data there does seem to be similar responses. So the standard right now is 4 to 6 cycles of chemotherapy, and then patients are observed. There is no role for maintenance. Unfortunately, like in non-small cell lung cancer and adenocarcinoma, we can give maintenance Pemetrexed. There is no data showing that Pemetrexed is improved survival in mesothelioma. There's some phase 2 data suggesting that it might be beneficial, and there is an ongoing randomized phase 2 study looking at this CALGB, or Alliance now, I guess. It's accruing very poorly, and I'm not sure if we're going to be able to get data for that or not. What about second-line treatment? Well, there's a variety of agents that have been tried and used, single-agent gem, single-agent vinorelbine, and some combination gem, vinorelbine, everubicin gem. I've never really given that. But response rates are really low. Single-digit is not unusual, maybe on the average somewhere around 10, maybe 15% response rates in second-line. There is no clear standard for second-line therapy in these patients. So have we made any progress since Vogelzang's data 2003? Have we made anything new? Well, it's like Thomas Edison reportedly said when he invented the light bulb, he's not failed never. He just found 10,000 ways it didn't work. And we've had a lot of negative data in mesothelioma the last 10 years. But on the horizon, and just recently, there are some other positive trials. And so it does, I think we are making some steps forward. Angiogenesis is something, it's a standard of care we use in non-small cell lung cancer. What about that in mesothelioma? Well, there's a variety of agents that work to inhibit VEGF signaling, antibodies to VEGF like bevacizumab, the VEGF receptor tyrosine kinase inhibitors, several of those, VEGF trap, and more recently ramucirumab as a VEGF receptor 2 antibody. In initial studies, there's a randomized trial that Hedy Kindler did. It was published a few years ago using, in this case, cisplatin and gemcitabine as the backbone regimen in combination with bevacizumab. And as you can see, these two curves are superimposable. There was no difference in survival in patients who got bevacizumab. What was interesting, though, is that plasma VEGF levels were prognostic. So patients who had a high VEGF level were more likely to have a worsened survival. So it's an interesting phenomenon, and so certainly makes you think about, is there some role for VEGF inhibition in mesothelioma? Well, we have some, So the other targeted therapies looking at VEGF, a lot of small molecule inhibitors of VEGF, all of which is in single agent therapy showed very little activity, single digit response rates. And so nothing really moving forward there over several years. The most recent foray into antiangiogenic therapy is the MAPS trial. So this was a trial done in France, very elegantly done. Again, now using the standard backbone, the cisplatin pemetrexed, 6 cycles, and randomized to with or without bevacizumab. Patients who received bevacizumab arm were allowed to continue on with maintenance. And there was no crossover design in this trial. So it was a phase 3 randomized trial with a primary endpoint of overall survival and secondary endpoints of PFS and quality studies. So the results of the study showed that the addition of bevacizumab had a significant improvement in progression-free survival. So hazard ratio 0.61, a clear separation of the curves, and overall about a little over 2 months survival benefit on PFS. It also improved overall survival. So this is a little over 2-month improvement in overall survival. And now pushing that median survival in this study for the combination arm over 18, almost 19 months. And it was statistically significant. So the conclusions of this study showed that adding bevacizumab to the standard cisplatin pemetrexed backbone improved progression-free survival and overall survival. Now, there were noted to be some higher rates of toxicity, some grade 3 and 4 toxicities, primarily hypertension and thromboembolic events, but there was no impact on quality of life measures. And the amount of chemotherapy was able to be, and both arms were equal. So in this study as well, VEGF levels were prognostic. Patients with high VEGF levels had a worsened outcome, overall survival, but it was not predictive of benefit. So VEGF, while prognostic, is not a good biomarker to determine who should get bevacizumab. So is this a new paradigm for first-line treatment? I don't know, maybe. What I think is interesting is that in looking at some studies that are going forward, we're now, and the FDA is looking at this now as incorporating how bevacizumab treatment will be incorporated into future studies looking at first-line therapies. Other first-line data that we have is interesting is looking at a vaccine to mesothelin. So CRS-207 is a live Listeria bacterial vaccine. It's a live attenuated, double deleted, has deletion of 2 virulence genes, and it also expresses the human mesothelin gene. So this has been used in combination with standard chemotherapy. It's priming vaccines followed by standard chemotherapy, and also boost and maintenance vaccines are given afterwards. In the first data that we had for this study, 26 patients were enrolled at 5 sites around the US, and we found an overall response rate of 63% and disease control rate of 92%. This compared quite favorably with what was expected with chemotherapy alone. Toxicities were predictable. There were some rigors and fevers, all but mild and manageable. So based on that initial experience with those 26 patients, the trial was expanded to 40 patients. I think it's actually expanded to 60 patients now, and we have just some updated data from a couple of months ago. So here's the trial schema. Patients receive 2 priming vaccinations with CRS-207, 2 weeks apart, and then they get standard chemotherapy, cisplatin pemetrexed. 6 cycles, and 4 to 6 cycles. Most patients are receiving 6, and then go on to get 2 boost vaccinations after chemotherapy, and with the option of going on to get maintenance vaccines every 8 weeks. The most recent iteration of the protocol, that we've added a low-dose Cytoxan prior to the priming vaccines and the boost vaccines with the idea of trying to reduce T regulatory cells. So here's the most updated data we have. In a waterfall plot, you can see responses with the lines below the line, the bars below the line. About 85% of patients have shown some sort of tumor shrinkage. The overall overall response rate was about 59%, with additional 35% having stable disease. And this is the overall survival data that we have with a median overall survival of 20.1 months. Again, looks quite promising. So the data for this study so far, we feel that CRS-207 appears to be safe. It can be given concurrently or given as a priming vaccine and boost vaccine with cisplatin pemetrexed. Toxicities are predictable, transient, mild, and doesn't seem to add any toxicity to the overall regimen. And the combination therapies have about a 90% disease control rate, 59% overall response rate, which is better than historical controls. When we look back at the Vogelzang data and other studies, 25 to 40% overall response rates. So based on this data, there's an international randomized phase 3 trial that is being prepared now, cisplatin pemetrexed with or without CRS-207. We're still trying to figure out what to do with the bevacizumab. So what about other options for treatment? So these are in patients who have progressed after standard chemotherapies. The antibody drug conjugate, it's the Bayer compound 949343 or anatinib or ravtansine. This is a anti-mesothelin antibody that's conjugated to a DM4 antitubulin cytotoxic agent. So it binds to the cells and then in high concentration can deliver the DM4 cytotoxin to the cells. So this is data that was presented by Rafid Hassan at a recent meeting a couple months ago, World Lung Conference. These are in a dose-finding study, and then eventually at the maximum tolerated dose of 6.5 milligrams per kilo every 3 weeks. It showed some very promising response rate data. So we look at all patients in the mesothelioma cohort, 31% of those patients had a response, and with a 75% disease control rate. So that's, again, sort of similar to, this is very promising. And for you look at second-line data, these are mostly second-line patients. This appears to be better than what we would expect. So this is quite encouraging. Here's the swimmer's plot of this data, and you can see that of those patients that are responding, these responses can be quite durable. We have responses going out, over 2 years in some of these patients. So this looks like a particularly interesting compound, and this is also going forward. So the conclusions from this trial was that anatinib ravtansine at the maximum tolerated dose showed encouraging efficacy in patients with advanced mesothelioma. Drug-related events were reversible and non-life-threatening. The only thing that was interesting was that there was keratitis was one of the particular toxicities, and as well as some peripheral neuropathy. The randomized phase 2 trial of this compound versus vinorelbine is now underway, and the part of the trial is that patients require eye exams at every visit to evaluate for keratitis. So it's a little bit cumbersome, but I think it's a promising compound. So what about immunotherapies? Well, so this is some data that we presented recently. This is looking at single-agent pembrolizumab in patients with mesothelioma who had progressed on prior therapies. As you are well aware, PD-L1 expression is something that can be associated with immune suppression in the tumor microenvironment. And if you look at mesothelioma specimens, they do express PD-L1. In fact, there's around half of mesothelioma cell specimens will have high levels of PD-L1 expression. And PD-L1 expression is associated with a poor prognosis in mesothelioma. The data that was presented from the Mayo group, median overall survival was about 5 months in patients who had a high PD-L1 expression versus 14.5 months with patients who are PD-L1 negative. So PD-L1 positivity is an independent risk factor for poor outcomes. As you know from lung cancer and melanoma, PD-L1 antibodies, pembrolizumab has a robust anti-tumor activity in a variety of tumor types. So this was the Keynote 028 study. It was a multi-cohort study in advanced solid tumors, and this is the data from the pembrolizumab portion of this trial. Patients were given pembrolizumab at 10 milligrams per kilo every 2 weeks. And then were assessed for response. Patients who had a complete or partial response continued on the therapy up to a total of 24 months, and then patients who had progression were discontinued from the study. Responses were assessed every 8 weeks by CT scan. The primary endpoint of the study was overall response rate. So here's the data that we have for this as a cutoff in June. Our overall response rate in 25 patients, our response rate was 28%. We also had a disease control rate of 76%. So again, this is quite encouraging in the immunotherapy realm. In the waterfall plot, about a little over 60% of patients had some decrease in tumor volume from the baseline. And in the swimmer's plot on the right side, you see that there was, at the time of the data cutoff, 4 of the 7 responses were ongoing, and some of those responses were approaching almost a year. So some of these responses, when you do have responses, can be quite durable. The median duration of response had not even been met yet on the study. Here's the progression-free survival data for the trial. Median progression-free survival was 5.8 months, and the 6-month survival rate was 50%. Again, this compares favorably to historical controls. So in meso, pembrolizumab has a favorable and manageable safety profile, encouraging response rate of 28% with a 76% disease control rate, again, better than historical controls. And some of these data responses are ongoing. In data I didn't show, there doesn't appear to be a relationship with PD-L1 expression that we can find statistically, although it's a small, 25 patients, so it's hard to know. But this response rate and the PFS is certainly encouraging. Now, there is a ongoing study that was just opened up a little while ago, a phase 2 trial at the University of Chicago. Hetty Kindler is leading that study, and so hopefully we'll have some more data in a larger trial. What about targeted therapies for mesothelioma? Well, there hasn't been an easily identified rational target so far. The next-gen sequencing to detect these actionable or druggable mutations haven't identified a clear target in mesothelioma. And there are trials of targeted therapies that are ongoing. Focal adhesion kinase was a particularly interesting target. This is a kind of a very promiscuous kinase that is involved in cell cycle regulation and growth, invasion. So inhibition by Merlin, the protein Merlin, which is encoded by NF2, limits cell growth through inhibition of FAC. So Merlin-deficient tumors may be particularly sensitive to FAC inhibition. And this NF2 loss is actually one of the common mutations that are seen in mesothelioma. So FAC is a central player in these tumor-promoting events, cell cycle proliferation, gene expression, and invasion. And defactinib is a small molecule inhibitor of FAC. So this was looked at in the COMMAND trial. So the COMMAND trial was in patients who had previously been treated with chemotherapy, had stable or better disease, and they were randomized to receive either defactinib, the FAC inhibitor, or placebo. This is a registration-directed phase 3 trial. It was targeting to accrue 372 patients worldwide. But what happened? Unfortunately, it was stopped early for futility. So this trial was a negative study, and I borrowed that from Corey, the negative thing. That's a nice effect. So that unfortunately, it doesn't look like FAC inhibition is going to be a modality that we can use in these patients. The data hasn't been presented yet. But another targeted therapy is looking at the PI3 kinase pathway, a PI3 mTOR dual inhibitor. So again, signaling pathways important in cell cycle progression and cell survival. And there's a PI3 kinase mTOR dual inhibitor called LY3023414. It just rolls off the tongue, doesn't it? That one is looking at inhibition, in combination with first-line chemotherapy, cisplatin Pemetrexed. That's a dose escalation study. And then also in recurrent mesothelioma, we're looking at this drug and to find the recommended phase 2 dose, and it will go into an expansion cohort with 40 patients. Both these trials are accruing, don't have any data yet. So this just in, and literally just in, there was a randomized trial using a WT1 vaccine that was just unblinded a couple weeks ago, and for futility of the control arm. This trial was at, I think, at Memorial and MD Anderson as well. It was a randomized phase 2 trial of a WT1 analog peptide vaccine versus a control or sham vaccine after surgery and chemotherapy. So 40 patients were enrolled, and the trial was unblinded because it showed an overall survival of 39 months in the vaccine arm versus 18 months in the patients who were getting the sham vaccine. PFS was also doubled. This data is actually being presented today at a meeting in Kyoto, Japan. But this is I think, really interesting. And this, certainly warrants a larger study if the data bears out. This is just released from the company, so I really don't have any of the details of the study, but I thought it was quite remarkable. So we'll hopefully know more maybe by the end of the day. So in conclusion, platinum Pemetrexed remains a standard for first-line treatment. The addition of bevacizumab to CISPEM may be beneficial to patients. Whether or not it gets adopted widely, I don't know. It's that financial toxicity of an already expensive regimen with Pemetrexed. CRS-207, this looks like to be a safe and effective in combination with first-line therapy and ongoing. We're going to be doing a phase 3 trial. And then targeting mesothelin with an antibody drug conjugate also is a rational approach that will be studied further. Immunotherapy with pembrolizumab has meaningful activity in these previously treated mesothelioma patients and is worthy of further study. And then targeted therapy, disappointing, but there's some rational targets then that are going to be evaluated in our ongoing trials. And I think inhibition of multiple pathways may be the way to go. And then just immunotherapy with this vaccine in combination with surgery looks like quite an interesting approach. And it may be that we don't have to do chemotherapy or surgery or immunotherapy, but we do them all together.